Good morning, everyone. My name is Mouaz Al-Mallah. I'm the Director of Cardiac PET at the Houston Methodist DeBakey Cardiovascular Center. And with me today is Dr. James Udelson. He's the Chief of Cardiology at Tufts University School of Medicine and the Director of Nuclear Cardiology. He's also a past president of the American Society of Nuclear Cardiology. And he just gave a great talk about testing our tests, the evolution of evidence for cardiac imaging. This lecture is named after Dr. Mario Verani, who's the founding director of our nuclear cardiology lab. Good morning, doctor.
Good morning, how are you?
Good.
Great to be here.
So this lecture is named after Dr. Mario Verani. Can you tell us more about your interaction and relation with Dr. Verani?
So Mario Verani was really one of the, you might call the founding fathers of the field of nuclear cardiology, and he started publishing papers back in the mid to late 1970s. It was really quite remarkable, and you know, a group of people around the country, around the world, a relatively small group of people, really birthed the field back then. Barry Zaret, Mario, George Beller, and others. And you know, over the years, he was really out in front in so many different areas, whether it was using thallium for detecting whether coronary disease was present or not, early studies of prognosis, early studies of myocardial viability, early studies of pharmacologic stress testing, which he did so much. It's actually quite remarkable that how many of the areas within the field that he touched.
So, Dr. Udelson, you started your work in nuclear cardiology, but as we saw from the grand round, it evolved to other imaging modalities. It sounds like cardiac CT is starting to play an important role in our assessment and workup of patients, especially those coming to the emergency room or presenting to the clinic with chest pain. However, it sounds like when we get referrals that some patients or some physicians might be confused where to start with which test. So in your current practice, where do you see the role of each imaging modality nowadays? You've shown us some great data in the lecture from nuclear cardiology, the ARRAISE trial, and then you showed us also some outstanding data from CT, from PROMISE, Cotard. We don't want to add layer testing so everybody gets both. We want to direct our resources and each patient to the appropriate test.
Right.
So how do you select your patients in your practice?
So I think if you boil down all of the data, I think a reasonable approach in this day and age is step one is to think about the pretest probability. You know, you have a patient in front of you with some kind of chest pain syndrome, and by using either standard Diamond-Forrester type pretest probability approach or newer approaches, you know, think about where that patient falls on the spectrum of pretest probability. If it's very low, if it's lower on the lower end, I think CT or even coronary calcium imaging by itself is a very reasonable way to start. The vast majority of those patients don't have coronary disease, and CT, you know, fast, in contemporary practice, low radiation exposure, outstanding negative predictive value, and you're done. So I think at that end of the spectrum, CT is a reasonable place to go. We're also, as we discussed, testing out some tools to figure out who doesn't really need testing at all. That we'll know more about in a couple years. Once you're in the intermediate and high probability end of the spectrum, particularly if patients have symptoms with exertion, you know, I think there's still an important role for functional testing, functional imaging of some sort, whether it's SPECT or PET or stress echo. But still, CT performs well in those areas as well.
So in terms of functional imaging, as you mentioned, I mean, the menu is too big. I mean, we have nuclear SPECT and PET, we have stress echo, we have perfusion CMR. In terms of SPECT, if you look at the performance, maybe at the community level, we may not be delivering as we would like to deliver. Do you see a point like in adding a calcium score to these studies to at least enhance the assessment of atherosclerosis and maybe guide some patient management, even among those with normal perfusion?
You know, I think so. And, you know, calcium imaging could also really be sort of a gatekeeper, as someone mentioned during the lecture, that maybe you mentioned it, that in someone in the lower pretest probability end of the spectrum, if they have a calcium score of 0, the likelihood that there's some obstructive plaque causing exertional symptoms is virtually 0. So you've started with a very fast, inexpensive, low radiation burden test as a gatekeeper. If you have a non-zero calcium score, particularly if it's in the hundreds, you know, then move on to your functional test. So that also, you know, is a quite reasonable way to do it. And I think you're also asking about the other way. Let's say you have a patient with exertional symptoms, you do a stress anything, nuclear echo, and it's normal. You absolutely haven't ruled out that they have atherosclerosis. And you could then go on to do a coronary calcium score. Now, do we do that in everybody? No, because, why is that? Because strictly speaking, I guess, we don't really know whether that knowledge changes what we're going to do. You know, we'd like to think, or I like to think, that if you have a non-zero calcium score, then you should probably be on, let's say, a high-dose statin. But we really don't know that, you know, from randomized trials, whether that's better than just not doing it and treat the person with aggressive primary prevention. So that is a gap in our knowledge, I think, at this point.
Yeah, but in terms of calcium scores, I mean, if you look at it, I personally feel that this is kind of more underutilized, because it does, even in the Scott Hart analysis, when they looked at all the detailed plaque analysis, and then in terms of predicting outcomes that you get with the fancy CT and all the detailed analysis, the recent Jack paper, when they looked at in the multivariate analysis, just a simple calcium score was the only predictor of outcome when you take out all other characteristics. So I think we have to look at the atherosclerotic burden of these patients and try to not give patients some false sense of security when they are having a normal perfusion study that they are free of disease. They might have tons of disease from atherosclerosis.
That's completely correct. Again, to me, and remember, the patients in Scott Hart were symptomatic patients. So, you know, whether a calcium score alone would have been enough for their clinicians to manage them, I'm not sure. So again, that's a big gap in our knowledge, I would say.
And as you said, I mean, if you look also at the PROMISE data, the event rate, I mean, it was intended to enroll intermediate risk patients, but then the event rate over 5 years was almost 3%, which is probably considered nowadays a low-risk population based per our standards.
That's right.
So
the problem is we take really good care of patients in contemporary practice, and it's really challenging to show, you know, one modality is better than another when in stable outpatients they're going to do generally pretty well, and you're trying to find those 2%.
Yeah. So just to mention that we are also on Twitter, Facebook, and and we're getting questions from there. So there is a question that we just received from our audience looking at functional testing in asymptomatic patients, or even anatomical testing in these patients. Where do you think the role of imaging in primary prevention, I mean, compared to other simple exercise tests and other?
Now, we still get referrals to our nuclear lab for stress testing in asymptomatic people, for instance, with a bad family history. They're worried about it, they reported that to their primary care physician, and they order a stress nuclear test, let's say, or a stress echo. That's not the right test to do, I would say, because really functional testing is looking for, you know, obstructive or stenoses that cause blood flow, coronary flow reserve abnormality. In those situations, what the patient wants to know about is, do I have any coronary atherosclerosis early? And there, coronary calcium imaging really is the way to go. You know, if they have a non-zero coronary calcium score, again, we don't know exactly what to do with that from randomized trials because there hasn't been one. However, there's overwhelming observational data that suggests that those people, should be treated with more aggressive prevention than an asymptomatic primary prevention person.
Excellent. So continuing with the questions, I know that you closed your grand round by a question about a word about the role of mentorship, especially with Mario's role in mentorship and how he educated a whole class of imagers across the country. So the question is, would you advise fellows or junior faculty to pick up a good mentor? Any specific qualities?
Well, part of it is luck, I guess. I personally fell into it, I think. But usually from a fellow or junior faculty perspective, particularly junior faculty, most junior faculty have some area of interest, whether it's heart failure or cardiac imaging or interventional or EP. So, you're clearly seeking out people within that field. And, part of it is a personal relationship, part of it is seeing how others have benefited from their mentorship, and you find that person, get involved in projects with them, and perform. I mean, part of it is performance, that, a good mentor-mentee relationship is that the mentee brings some value to the mentor by helping them in their work, and the mentor in turn, helps the mentee, with a career pathway. So in essence, it's really a two-way street. But I think identifying the person is what field you're in, what have others experienced with the various senior faculty in that field, and just reach out and get involved in projects.
And with the changes in communication nowadays, does the mentor has to be in the mentee in the same? Do they have to be in the same institution?
Not necessarily. No, that's a wonderful question. Not necessarily. There may be someone who is interested and does research in some area that you're interested in, and they're not at your institution. Reach out and email in any way possible. And part of it again is, can you as the junior person bring some value to what they're doing, and they in turn in theory should help you as the junior person. And I see that happening all the time now with ambitious young fellows and junior faculty. And I get emails like that too, and if it happens to be something where I could use some help, that may work really well. I benefited from that as well, from people like Mario, Verani, or George Beller, or Gene Brownwald, and others who, I've interacted with over time. And, people are looking out for talented young people.
Now, on the other end, so from the mentor perspective, sometimes you get too many emails, and how do you pick a good mentee, and what characteristics you look on those people?
That is correct. That's a hard one. I think if it's someone who, again, from afar, someone you don't know, if it's someone who brings certain skills to the table or knowledge to the table that fit in with what you happen to be doing at that moment, it's luck. That's where the luck comes in. But I do get a lot of emails, people I would just like to work with you, and I can only have so many people, and of course our own fellows are my primary goal.
And there are some kind of like mentorship opportunities that happen in national meetings and international meetings. How effective are these in your opinion?
Well, I think they're very effective. All professional societies, whether it's American Society of Nuclear Cardiology, the ACC, the Heart Failure Society, all of them have some kind of program focusing on junior people, fellowship people, emerging faculty. So as a junior person, whether it's fellow or junior faculty who is in a field, find your way to that professional society and look at their website and connect yourself with someone who can help direct you into their particular fellowship pathway.
All right, so that was a little bit of a detour from topic. Let's get back to imaging. And so a quick point, we talked about the lower risk patients on the spectrum. So now moving on to the higher end of the spectrum, patients with metabolic syndrome, diabetes, obesity, and we're seeing an increase on these increase in the prevalence of these patients and those who are showing up to our labs. Do you think PET versus SPECT versus CT for this type of population? I mean, I know that there is data to support more functional imaging in this, as you just alluded to, but within functional imaging, PET versus SPECT in this population?
Well, at some point, CT probably becomes a little problematic or CT angiography if people are going to have a lot of coronary calcium. So as you get up into that end of the spectrum in people with multiple risk factors and comorbidities, it's, as you mentioned, that could undermine CT angiography a bit. And of course, you don't know till you get the calcium imaging. I do think at that end of the spectrum, either exercise or pharmacologic stress imaging, PET does, in meta-analyses, perform in terms of sensitivity, specificity, a little bit better than SPECT. In all comers. I mean, it's probably distinctly better in obese patients, large-breasted patients, difficult to image patients, just because of its better imaging characteristics. So in some ways, you can select patients within that paradigm for who gets what. But by the way, I mean, a key element is expertise, local expertise. If you don't have a lot of experience in something, that shouldn't be your primary go-to, I think. And a PET program, it is not plug and play. You need someone who knows what they're doing, a lot of experience watching over the quality of the program, just as you do with anything.
Exactly.
So, in that situation, if you have excellent quality cardiac PET perfusion imaging, you might go with that.
Now, cardiac PET is obviously very appealing to a lot of people. As you said, there are the quality issues, but also the volume issues. And now, most of them, either you have to be closer to a cyclotron or you have enough volume to support a generator. But now there are some potential tools that are being tested that you just alluded to in the grand round. Can you speak a little bit more about some of these agents?
So there are two in development, and I guess I do some work with both. So one is fluoropiridaz, an F18 PET agent, and the potential workflow advantage of fluoropiridaz is it could be delivered by unit dose, so you don't have to buy a monthly generator. So that agent is in late phase pivotal trials, and hopefully, if all that works, it would be available. The images, as you've seen, are really quite excellent. The other agent is O15 water, which is being developed as a perfusion agent. It's probably the most pure perfusion agent in terms of its characteristics to track flow. You do need an on-site cyclotron, so its use in theory would be limited to centers that have that. And that is at some point soon to start pivotal trials. So it's being widely used in Europe, actually, but not here in the United States.
Interesting. So now moving back to CT, and it sounds like there are a lot of information that we get from CT in addition to calcium and whether there's stenosis or not. And also cardiac CT has not only been just coronaries, we look at valves and preparation for TAVRs, there are many other aortas, many other indications. Where do you think, if someone is just like finishing cardiology fellowship and they want to learn different modalities and they're interested within nuclear CT, what advice you have for them in terms of training? Shall they focus on one modality, try to be more multimodality, learn CT more on one aspect, or focus on everything? And what general advice you have for people?
A few years ago, as you know, there was some efforts being made to create multimodality imaging fellowships that made people expert in echo, CT, MR, nuclear, and there are still some that do that. I think that's 4 is probably too many, actually. So I think my advice would be probably to pick at least 2. Maybe echo and CT, or nuclear and MR, or some combination that involves echo and nuclear, only because when you go out to look for positions, most places would want help in those areas because those are still the high volume areas. But CT and MR are emerging, and they are probably going to keep growing, and so you need help in those areas as well. If someone just comes out of training and they're only expert in CT imaging, it's just simply going to be harder for them to find a position that just is so narrowly focused. So I would say pick two, and one of the two should include nuclear or echo.
Yeah, and this brings us to one issue which has been kind of among the trainees you hear, and also among those of us who are doing some recertifications. Now, if you're going to get into one modality, you have to do echo board, nuclear board, CT board, and now there's CMR board. Are there any efforts across the different professional societies to try to bring it to become like more one unified training like we have for ABIM, like training for EP or heart failure or that congenital, or even potentially go the route of potentially one board with majors, minors, kind of?
You know, there's been discussions. It's a really hard one because, you know, when you have 4 modalities, and you know, and there are still plenty of people who are general clinical cardiologists who are highly experienced and excellent in echocardiography and going out into practice, and they don't want to do CT or MR, or it's irrelevant in their practice, and maybe they do nuclear or maybe they don't. So how would that fit in with them? So there are so many different reasons why it would be hard to do a multimodality in the absence of each of the individual ones. You know, I could almost see some combination of CT and MR, but again, they're very different, and some people might have a lot of passion for one and not the other. So I think I guess I would say there's a clear recognition of the problem of multiple boards, but the solution is not instantly at hand.
All right. And finally, going back to advances in the field, where do you see the field of imaging, and maybe a little bit more focus on nuclear cardiology in 10 years? So where are we heading? More precision medicine, more personalized medicine, more no testing? Where do you see where we're going?
So I think all of the above. I think we are going to be forced to be better choosers of what we do. And I think payers eventually will say something like, okay, you know, you have a patient with chest pain that you want to do testing. Here's one lump. I'm going to give you $800 for every one of those patients in your system. And then we, you know, will have to apportion that appropriately. You know, for the people on the very low likelihood end of the spectrum, we might just do coronary calcium imaging as a gatekeeper. Very inexpensive, fast. On those people, we'll make some money, you know, profit margin. On the other end of the spectrum, we will do some cardiac PET studies, which are more expensive. We'll probably lose some money on those. But on the whole, we'll be able to say, you know, if we have, you know, X thousand of patients and we apportion it, so, you know, we know our population, you know, on the whole, we don't want to lose money. So, and that's probably how it'll play out. And, you know, with the imposition at some point of appropriate use criteria into our ordering stream, you know, that will play a role. So I think from a practice perspective, that's what's going to happen, I think. From a research and development perspective, you know, time marches on and the imaging modalities get better and better. You know, whether molecular imaging of processes within the myocardium or within the vascular wall, you know, ever play out into something that's clinically useful is still somewhat uncertain, but research will continue.
And probably will be doing more of the reassurance, no testing kind of population.
Potentially, you know, we know that 80 to 90% of outpatients that get tested have normal tests, and if we could, you know, knock off 10, 15, 20% of those, you know, we've been developing a tool to predict who has an extremely low likelihood of a positive test. If we can do that, and we're testing it prospectively now with reassurance to the patient and the provider, you know, that might be a very efficient thing to do.
Interesting. Any last word you want to add?
No, I appreciate being here, and you know, I think about Mario often, and particularly when I come here.
All right. It has been a pleasure to have you here. Ladies and gentlemen, thanks for watching, and it has been a pleasure to have Dr. Udelson with us this morning.
Thank you so much.